All right, I guess we're going to get started for the afternoon. We have two more presentations for this afternoon. And just a reminder, I saw some of you scanning the QR code, but if you want to get credit for the nursing course today, you have to scan that QR code to fill out the survey. And so our first presenter for the afternoon is our own Katie Dickerman.
Hi, everybody. I'm sorry for those of you I have my back to. Today, we're going to be talking about ERCP complications. My style tends to be pretty loose, so if you have any questions, comments, please interrupt me, raise your hand, and we can just have like a nice little dialogue. But we'll go ahead and get started. I have no disclosures. Our objectives today, we're going to review the indications for ERCP, describe the most common complications related to the ERCP, identify early signs of post-ERCP complications, and review the nursing implications for caring for patients following ERCP. So I always like to start with a little basic anatomy. A lot of us are GI folks, not a lot of us deal with ERCP, so we'll just kind of orient you here. So this is the hepatobiliary system. The large red organ is the liver. The liver drains into the bile duct. The gallbladder also drains into the bile duct, which is this green organ. And the bile duct drains into the small bowel, the second portion of the duodenum, through the ampulla of Vader or the ampulla. Pancreas sits here across the abdomen, and it also drains into the ampulla of Vader. So you have this common channel in the second portion of the duodenum where both ducts empty. And that'll be important for the complications discussion here in a bit. So the functions of the gallbladder, of the common bile duct and the pancreatic duct, are to drain the gallbladder, liver, and the pancreas, respectively. The two main ducts can converge at the common junction and the duodenum, second portion of the duodenum. The most common reason we do ERCPs is because there's a blockage somewhere around here. So the pancreatic duct may be blocked, the bile duct may be blocked, the ampulla may be blocked. So the procedure we'll discuss today in more depth is the ERCP, or endoscopic retrograde cholangiopancreatography, if you want to say it 5 times fast, and its associated complications. So this is an endoscopic procedure. Endoscopic procedure that uses fluoroscopy. So the patient is put to sleep under general anesthesia. Our institution uses general anesthesia for all ERCPs. Some may use monitored anesthesia care, but they are asleep regardless. The scope is inserted through the mouth, into the esophagus, down into the stomach, and then into the second portion of the duodenum, here where the ampulla is, where the bile duct and the pancreatic duct empty. This particular scope is a side viewing scope. So rather than a gastroscope that has a camera on the tip, this one has a camera on the side, so the physicians can see the papilla or the ampulla. Depending on the indication for the procedure, the bile duct may be cannulated, or the pancreatic duct may be cannulated, or both. We put a wire up into the duct that we're going in to treat. We inject contrast media and then take fluoroscopic images of the duct to evaluate what's going on in there. As you can imagine, we can't get our duodenoscope up into the ducts because the ducts are smaller. There are a couple of smaller scopes that can get up there, but for our purposes, the wire goes up, the contrast media goes in, and we are able to evaluate the ducts that way. So fluoroscopy, for those of you who are not familiar, is basically live time video x-ray. So the doc has a pedal at the base of his or her body, presses that takes live x-rays of the wire and the contrast going up into the ducts so we can evaluate what's going on. This is a picture of fluoroscopy. So again, normal anatomy, and then the bile duct is being cannulated with a wire. Sorry, this is the scope here. Down to the second portion of the duodenum, the wire goes into the bile duct, contrast goes up and opacifies the duct. That's this here. This is the cystic duct, which connects to the gallbladder, cystic duct, gallbladder. So this is a really good picture of what the fluoroscopic image of the bile duct looks like. Okay, so indications for ERCP. Most of the time, ERCPs are going to be done for biliary indications or bile duct related disease. So the most common types of biliary indications include a bile duct stone or sludge. So this is a little small up there, but you can appreciate gallbladders full of stones or sludge. Something slips into the bile duct and gets stuck. That's called a bile duct stone or choledocholithiasis. Biliary sludge can do the same thing, can exit from the gallbladder, get into the duct, and can cause an obstruction, which can lead to jaundice, elevated liver numbers, sometimes an infection. And then ultimately, these can also lead to pancreatitis because they're exiting through the common channel. Biliary strictures can be benign or malignant. Sometimes they're inflammatory from stone disease or from related inflammation or infection. So a stricture is a narrowing in the biliary tree somewhere. This is an example of a common bile duct stricture. You can also get strictures up high, and those can be treated with ERCP. A bile leak can occur as a result from a surgery or a trauma, such as gallbladder removal can result in bile duct injury. We also see people who have like polytraumas and are hit by cars or stab wounds to the abdomen. That can also lead to a bile leak. So the bile, as you can imagine, spills out into the abdomen, and that's very painful for patients. If this is a result of a surgical intervention, which can happen, usually a drain is placed into the abdomen at the time of surgery to drain the bile, and then we can go in and treat the bile leak. Cholecystitis is another indication for an ERCP for patients who are not surgical candidates or who are poor surgical candidates, such as patients who have cirrhosis or other end-stage organ disease. As you can imagine, the cholecystitis needs to be treated. And if we can't treat that surgically, oftentimes we can go in and put a stent across the cystic duct, and then it will drain into the duodenum in the natural course to treat that. And then we can also proceed with an ERCP to take samples or biopsies of the bile duct, of the ampulla, or surrounding structures. So the other potential indications for ERCPs include pancreatic related indications. So again, bile duct, pancreatic duct, both converge at the ampulla, and we can treat the bile duct or the pancreatic duct. So reasons we might do a pancreatic ERCP include pancreatitis, including acute pancreatitis or chronic pancreatitis. So similar to a bile duct stone, the pancreatic duct can get stones in there. It's a different mechanism. The stones that are related to chronic pancreatitis occur because of narrowing or stricturing or scarring in the pancreatic duct related to chronic pancreatitis disease. And then the outflow from the duct causes a backlog of these juices, and it forms a stone. So the stone, as you can imagine, becomes obstructive, can be very painful for patients. So we can go in, sweep out that duct and or place a stent to get that flow going again. IPMNs are mucinous neoplasms that are precancerous. Most of the time they do not turn into cancer, and they're often incidentally found. IPMNs can be found in the side branches of the pancreatic duct or the main duct of the pancreas. For our purposes, if a patient has a main duct IPMN, we may go in with an ERCP, put a stent into the pancreatic duct to drain that, sample it, get a diagnosis as a bridge likely to surgery. And then pancreatic duct leak, similar to that of a bile leak, the duct gets disrupted somewhere. Most of the time, it's either from a trauma, surgery, or chronic pancreatitis, and then the duct leaks. So the juices that should be flowing out actually go out into the abdomen, similar to a bile leak. We can go in to the pancreatic duct, put a stent across here to treat that. And then also similar to a biliary indication, we can get in there and sample or biopsy concerning lesions or areas in or near the pancreas. So procedural considerations. As we move into the specifics of these, it's important to note that many factors contribute to an individual's risk for complications, and some of these are outlined on this slide. So the indication for the procedure is really important to note, as that in and of itself can alter a patient's risk factors for ERCP complications and often dictates what type of intraprocedural steps are made. These include performing a sphincterotomy, which is essentially a cut at the ampulla at the base of the bile duct or the base of the pancreatic duct, or both, depending on the indication for the procedure. The placement of a stent or stents can factor into risks for developing certain complications. The use of SPY scope, which is a highly technical procedure where we can actually get a small scope up into the ducts. Use of that or lithotripsy to break up stone burden within one of the ducts can increase risks of complications. And then taking biopsies or sampling obviously can increase the risk of bleeding for these folks. Interestingly, a patient's anatomy also can really affect the risk factor profile for these patients. We often see patients who have a history of bariatric surgeries, including Roux-en-Y gastric bypass, sleeve gastrectomy, history of a liver transplant, or part or all of their pancreas removed, part of their stomach removed, or other non-surgical anatomic abnormalities, including diverticulum in the small bowel, which can involve the ampulla, which would, of course, make it very difficult to access that. If the common channel of the ampulla, where the bile duct and the pancreatic duct meet, if that channel is long, that can increase a patient's risk of complications. And then if they have anything else, such as pancreas divisum, which is where an accessory duct is used to drain the pancreas, these can all affect the risk profile for these patients. All right, so complications. So the ERCP, we kind of went over the specifics. Does anyone have any questions about the procedure before we move forward? Okay, so the super tiny. I don't do these procedures, so Lauren may be better to explain that.
I'm trying to think. It's probably about 8 millimeters. It fits through the ERCP scope, comes out the end, and then goes up. And then we switch the cameras from endo image to the SPY scope, so the physician can see, and you can actually see the wall of the pancreatic duct or the bile duct. It has a separate handle on it. Yep. It's a
good question. Okay, so the complications, so there are 4 main complications that are the major ones that we cite for post-ERCP pancreatitis or post-ERCP complications. The majority of ERCPs are largely safe and the risk profile is actually relatively low, but these are the 4 main ones that can occur and can really impact a patient's recovery and or medical course. So the 4 most common ERCP related complications are pancreatitis or inflammation of the pancreas or surrounding structure, which can involve surrounding structures, bleeding, which typically occurs within the GI tract as a result of performing a sphincterotomy, or less common can be a result of scope trauma, infection, which is largely due to introducing a foreign object into the GI tract, going up into the ducts, which are obviously very small, and then perforation, which can occur from any of the instruments we use during our procedure, but most commonly the scope causing a perf. Making a sphincterotomy can cause a perforation, or the guide wires we use can cause a perforation. Okay, so we're going to go through a couple case studies here. So our first case is a 71-year-old man with a history of GERD, prior cholecystectomy. He presented with right upper quadrant pain in the outpatient setting and was found to have a bile duct stone, for which he underwent an ERCP, also in the outpatient setting. We did a biliary sphincterotomy. We swept the duct with a balloon to remove the stone. The distal common bile duct was noted to be kind of narrowed, concerning for a stricture. So we did take some biopsies of that during the procedure. And then we placed a plastic stent into the bile duct because of that stricture to make sure that the duct outflow was adequate. He went home from the procedure, was feeling relatively well, but then presented to the emergency department 12 hours after leaving the hospital with acute epigastric pain. So his blood pressures was a little bit high, pulse was normal, no temperature, respiratory rate 16, and SpO2 on Ramir was 99%. His labs were notable for the following: elevated glucose, alk phos, and ALT elevation, and then a lipase greater than 6,000 and a leukocytosis. Physical exam was notable for a distended abdomen, which was tender with bowel sounds being hypoactive. He had an abdominal x-ray, which showed moderate colonic stool burden. The bile duct stent was in anticipated position, and there was no free air or pneumoperitoneum. Does anyone want to guess what he had? PEP, post-ERCP pancreatitis, which is the most common complication from an ERCP. So the incidence of acute pancreatitis is 3 to 9%. The 9% is largely related to folks who have sphincter of Oddi dysfunction or papillary stenosis, which is where that ampulla is kind of narrowed, scarred, stenosed, hard to access, for which we do a sphincterotomy. Most of the risk profile is closer to that 3% incidence. So risk factors include doing a sphincterotomy during the procedure or a balloon dilation of the ampulla or biliary orifice. Females are at higher risk. Patients with sphincter of Oddi dysfunction are at higher risk. And then if it's a difficult cannulation, so if we get down there with our duodenoscope and we really are having a hard time getting into the duct, that increases the risk of pancreatitis as well. So clinical manifestations typically include epigastric pain, often radiating to the back, nausea, vomiting, and bloating. Most of the time, post-ERCP pancreatitis occurs within 3 to 24 hours of the ERCP. So sometimes these patients go home and they're like, I was feeling fine post-procedure, go home, they eat something, and boom, there's their pain. So pancreatitis can be classified into mild, moderate, or severe categories. Mild acute pancreatitis, which is the majority of our cases following ERCP, is characterized by the absence of organ failure or local systemic complications. These patients usually recover within a couple of days. Moderately severe acute pancreatitis is characterized by transient organ dysfunction. So they may bump their creatinine to like 1.5, 1.8. They may get some SIRS criteria. Their vitals may suggest some hypotension, tachycardia, and typically, in order to fall under this moderate category, all of that organ dysfunction resolves within 48 hours. Severe acute pancreatitis is characterized by persistent organ failure that may involve multiple organs, and these patients often require prolonged hospitalization, often additional procedures and drain placement, rarely death, but it can happen. So the way we diagnose ERCP, post-ERCP pancreatitis is you have to meet 2 of the 3 criteria. Lipase has to be greater than 3 times the upper limit of normal, abdominal pain, and or radiographic imaging confirming pancreatitis. Typically, this is a CT scan. Ultrasound is not a very sensitive test to check for these, nor is an X-ray. So 2 of those 3, it's important to note that if you are caring for patients who are presenting with suspected pancreatitis, the lipase cannot just be elevated to meet that criteria. It has to be 3 times the upper limit of normal, and the upper limit of normal changes at each institution. So for example, at our medical campus here, the upper limit of normal for lipase is 82. So anyone with a lipase of 240 or over has an abdominal pain or radiologic imaging, has acute pancreatitis. Whereas we have other UC Health facilities where the upper limit of normal is 393. So that lipase would have to be up to 1100-1200 in order for that to be considered acute pancreatitis. So it's always good to look at what the upper limit of normal is. The treatment for these patients includes IV fluids, aggressive resuscitation to help decrease that risk of AKI and intravascular depletion. Limit oral intake. Anything you put into the stomach is going to trigger the pancreas to work. and help digest food. So the less you put into the stomach initially, the more rest the gut is going to get. So when in doubt, if you think your patient has pancreatitis, you can give them ice chips, but I probably wouldn't give them anything else until you hear more. Sometimes we have to start tube feeds, depending on the severity of the pancreatitis when they present, and then supportive care. And these are for kind of the more basic, straightforward pancreatitis episodes. Obviously, the more severe cases require additional workup. So this patient was admitted to the hospital. He was found to have moderate acute pancreatitis. We treated him with judicious IV fluids. We limited his oral intake. He did require nasojejunal tube feed placement for enteral feeds to promote bowel rest because his pain was persistent. He was hospitalized for 12 days. Aside from the tube placement, he did not require additional intervention, and he was able to make a full recovery. And his stricture was benign. So case 2, 42-year-old male with a history of metastatic colon cancer with liver metastases presenting to his oncologist for chemotherapy. He was found to have elevated LFTs on pre-treatment labs, hyperbilirubinemia, which prompted an urgent CT scan, which showed intrahepatic duct dilatation, so swelling of the ducts up in the liver, and worsening liver metastases, which were likely the cause of the bile duct or the intrahepatic ductal dilatation. He underwent an ERCP, sphincterotomy. He had never had an ERCP before. Findings of hepatic duct stricture. So up in those ducts into the liver, there was narrowing stricturing causing that upstream dilatation. We were able to balloon dilate some of those strictures, and then we placed a stent into the right intrahepatic duct and into the left intrahepatic duct to facilitate drainage. He remained hospitalized overnight and then developed a rising white count and malaise the next day. So on examination the following day, his blood pressure was a little bit soft, pulse was 90, he quickly developed a fever, and his oxygen saturation was 93% on room air. His LFTs did not make any significant change overnight. These were similar to what he came in with, but his white count went from 11,000 to 17,000. He was tender in the abdomen, particularly in the right upper quadrant. Bowel sounds were hypoactive. He had evidence of jaundice on exam. CT scan showed moderate left intrahepatic ductal dilatation. Moderate intrahepatic ductal dilatation and worsening metastatic disease in the liver. So he developed an infection from our ERCP. The incidence of infection after ERCP is less than 2%. And typically it manifests as cholangitis, which is a bile duct infection, or acute cholecystitis, meaning we can cause an infection of the gallbladder, bacteremia, or sepsis. The risk factors include patients who are immunocompromised for whatever reason, whether it be chemo, whether they be post-transplant on immunosuppressive medication. The other risks include inability to completely drain the obstruction. So he was at risk for a couple of reasons. He was on chemotherapy, cancer, and he had these obstructing masses in his liver that prohibited adequate drainage of the ducts. When we go in and we inject contrast media into these ducts, if they cannot adequately drain, the contrast can pool up in the ducts, and that can be a conduit for infection. Clinical manifestations typically include abdominal pain, distension, fevers, chills, rigors, often sepsis, leukocytosis, and elevated lactate. We diagnose this typically by laboratory testing. Oftentimes, these patients will come back with positive blood cultures within a day or two of the presentation. And then imaging can show if they have cholecystitis, duct dilatation that's potentially not being drained, and/or hepatic abscesses. So the treatment varies for these patients. Sometimes it's bowel rest, antibiotics, endoscopic closure. That should have been on the perforation slide. So that's incorrect, I apologize. But most of the time this is IV antibiotics. If they get hepatic abscesses, sometimes we have to put drains into them to drain it if we cannot get source control. Most of the time, these folks require an infectious disease consult, particularly if they're immunocompromised. So this patient was started on broad spectrum antibiotic therapy. His blood cultures grew E. coli on post-procedure day 2. He had a rising white blood cell count and persistently elevated LFTs. We ended up repeating an ERCP to go in dilate the strictures more, sweep out the duct, able to replace the stents, and his infection symptoms dramatically improved after that. He was hospitalized for 5 days and made a full recovery. All right. Case number 3. So a 72-year-old female with a history of obesity, heart failure, Parkinson's, admitted with right upper quadrant pain, elevated liver numbers, and concern for cholangitis with a rising white count. She was found to have bile duct stones on CT imaging, for which she underwent an ERCP with a biliary sphincterotomy, again, balloon sweep to remove that stone. There was no evidence of post-sphincterotomy bleeding at the time of the procedure. She was admitted, and overnight into the morning hours, she reported black stool around 4 a.m. The morning following the procedure. Her vital signs at the time were stable, but her hemoglobin after the melena stool was 8.2, down 2 grams. She was largely asymptomatic, but had 3 additional melena stools over about a 4-hour period. So as you can see, sorry. There we are. So as you can see, her blood pressure was normal, on the low end of normal, and then dropped to kind of softer. Heart rate was at around, or respiratory rate was around 20. Heart rate started to get a little tacky, and her SpO2 was 93%. Her hemoglobin dropped approximately 3 grams within 18 hours. Platelets were fine and INR was fine, so she was not coagulopathic. Her abdomen was soft, non-tender, non-distended, and she was otherwise well appearing other than the melena. So who wants to guess what her post-ERCP complication was? Bleeding, very good. So post-ERCP bleeding, incidence is about 1 to 2%. The risk factors include coagulopathy related possibly to liver disease or other underlying medical conditions. Low platelets can increase the risk, cirrhosis, which can lead to coagulopathy, use of anticoagulants or antiplatelets. If we do an extended sphincterotomy, and then cancer can increase the risk of post-ERCP bleeding, particularly if they have intraductal tumors or cholangiocarcinoma. I will say that there is a lot of data outlining how and when patients should stop their anticoagulants or antiplatelet therapy, depending on which agent it is. So it's really important from like a nursing perspective, if your patient is on antiplatelets or anticoagulants, that they are well educated on when to stop this medication prior to the procedure. It depends on the agent, whether it's 2 to 5 days, and also depends on their creatinine clearance, which can affect how long they need to hold this. So clinical manifestations of post-ERCP bleeding typically include overt signs of bleeding, including melena, hematemesis, often downtrending blood counts, and potentially LFT changes. They can develop a clot at the base of the bile duct where that sphincterotomy occurred, and that can cause a bile duct obstruction, which would manifest typically as rising liver numbers. So the way we diagnose this is with overt signs of bleeding. We often have to repeat the endoscopy to look for the source of bleeding, particularly if their counts are falling and or they become hemodynamically unstable. And then sometimes we get imaging to rule out an arterial bleed or a different source of bleeding that may not be from that ERCP, a result of the ERCP. Treatment typically is blood products, again, repeating the endoscopy to find and treat the source of bleeding. We treat these people with PPI twice daily. And then if they have an arterial bleed, we may send them to interventional radiology. So this patient ended up requiring a repeat endoscopy, which showed active oozing at the site of the biliary sphincterotomy. The physician irrigated this with saline and placed a covered metal stent into the bile duct, which was used to tamponade the bleeding site. So if we put this covered metal stent in, it puts pressure against the sphincterotomy site and often stops the bleeding. So it's a pretty common treatment for post-sphincterotomy bleeding. For this woman, there was no additional evidence of bleeding. Her hemoglobin stabled, and an EGD, she underwent an EGD in 4 weeks to remove the stent and did well. Okay, our final case, 62-year-old female with a history of diabetes, hypertension, referred for an ERCP for a bile duct obstruction and concern for a stricture, unclear if it was malignant or benign, but this was incidentally found on a CT scan for other reasons. The ERCP showed a distal bile duct stricture, which we brushed. The biliary sphincterotomy was made and a plastic stent was placed. She was discharged home feeling relatively good, came back to the emergency department 8 hours later with abdominal pain. So blood pressure, heart rate, respiratory rate is there. Her white count was 17,000 and her lactate was 4.2. Creatinine was a little bit elevated and her hemoglobin was relatively stable comparatively to prior labs. CT scan showed free air in the retroperitoneum and perihepatic space concerning for duodenal perforation. There was no free fluid, no pancreatitis, and the bile duct stent was in place. So this is kind of an obvious one, but what was her post-procedural complication? Perforation, correct. So the incidence of retroduodenal perforation for ERCP is pretty low. It's much lower than it used to be due to improved techniques and endoscopic procedures, but it's still about 0.5%. Even though it's that low, it can really affect patients' post-procedure course. So it's important to note that this is a risk. So the risk factors for patients for these types of perforations include anatomy, meaning is it difficult to get to their ampulla? Do they have duodenal narrowing? Do they have kind of a J-shaped stomach? Is it difficult to get the scope down there? The more difficult it is, the higher the risk we can cause an injury to the small bowel. Evidence of dilated bile duct prior to the procedure is an associated risk for perforation. And then if we do a sphincterotomy, there's a risk of perforation as well. As I mentioned earlier, the most likely causes of these perforations is either scope trauma or the sphincterotomy cutting and then it causing kind of a defect in that layer there. Clinical manifestations, feverish chills, leukocytosis, pain, and elevated lactate. Typically, it's infection type symptoms with related pain, sometimes abdominal distension, depending on the degree of the perforation. Largely, these are diagnosed via imaging, likely a CT scan or some sort of cross-sectional imaging. And then the treatment widely varies. They will be started on antibiotics if it's a very small, simple appearing defect on imaging. Sometimes we won't do anything besides for medical management. We'll give them strict bowel rest, put in an NG tube, limit their oral intake, let the antibiotics work, and let the body kind of heal the closure by itself. Sometimes these patients require surgical intervention. Sometimes we are able to repeat an endoscopy and go in and close the defect with a clip. So all of those are potential outcomes for these folks. Sometimes I should mention, oftentimes these perforations are actually seen during ERCP when the physician's withdrawing the scope. And if it's seen during the ERCP, oftentimes we'll treat the defect then and there with a clip, admit them to the hospital, kind of keep an eye on them. If they do well, then they can go home on antibiotics. So this patient was started on IV antibiotics. She had a surgical consult pretty quickly after she got to the emergency department and they took her to the OR. They did a gram patch over the defect to manage the small bowel defect, and then they placed a surgical drain. She was treated medically thereafter and she made a full recovery and her stricture was benign. So some less common complications just to kind of keep in the back of your head, but you don't need to know a lot about their risk profile. Cardiovascular and anesthesia related risks, as I said before, are patients who undergo ERCP at University Hospital get general anesthesia. Other facilities sometimes do monitored anesthesia care, so there are risks associated with that. Pneumothorax, subcutaneous emphysema, hepatic hematoma, air embolism in the portal venous system, splenic injury, or duodenal obstruction. So some nursing pearls for you all. Patient education is really important and can greatly improve the patient's understanding of the procedure and apprehension prior to going into the procedure. I really try to explain the procedure simply to patients and make sure that they kind of understand what the anatomy is, what we're doing with the scope, the wires, what the potential outcomes are, including possibility of stent placement, possibility of sphincterotomy, balloon dilation, et cetera. It's important to know that they'll be under anesthesia. The procedure can take anywhere from 60 minutes to 120 minutes or longer, kind of just depending on the indication and the complexity of the procedure. I explained the scope, how it goes down into the stomach, into the small bowel, and we evaluate the ducts via the wires and the contrast media. And then we might take biopsies if indicated. It's important to kind of know the basics of the complications, what to look for if patients call the office or call the endoscopy lab after they leave, or if they represent to your office or the emergency room, kind of keeping an eye out for those potential early signs and symptoms of pancreatitis, bleeding, infection, and perforation. It's also important to note the patient's general health. Are they at risk of bleeding because they have underlying medical conditions? Do they have the altered anatomy that would make this that would make the ERCP more difficult to achieve or higher risk for complications? And then their health literacy and their access to care. So in summary, there are a lot of different indications for ERCPs, including biliary and pancreatic etiologies, the biliary being the more common etiologies. Four most common types of post-ERCP complications include bleeding, infection, perforation, and pancreatitis. Procedural considerations affect the rate of post-procedure complications, including sphincterotomy, balloon dilation, biopsy, stent placement, et cetera. It's really important to identify the signs and symptoms early in order to optimize outcomes for these folks. And then nursing care, both intraprocedurally and post-procedurally, is important for early identification of signs and symptoms for patient education and intervention. And that's it. Yes, of course, please.
How often are you seeing, or do we see like bleeding or perforation after the procedure is completed? I guess I'm just curious.
Like immediately after, or like
Or
while
like
they're
they're
in the
representing, like
post-procedure
it's
area, or
delayed.
just, I'm sorry.
Like it's delayed.
Delayed is pretty rare. So typically perforation and bleeding occur within 12 to 24 hours of the procedure. Like I said before, kind of the perforations the physicians can sometimes identify during the procedure and treat. Bleeding is the same way. I should have mentioned that. So if we do a sphincterotomy and there's some post-sphincterotomy bleeding after we do our work in the duct and we're sweeping it out and taking a look, the physicians will look at that sphincterotomy site again and identify if there's a source of bleeding. So the delayed complications are pretty rare and the incidence is very low. With that said, particularly in our setting, we see these patients, we monitor them for a couple hours and send them off. And so we don't watch them for that full, 12 to 24 hours afterwards, which is appropriate. But we don't always see it within that first few hours when they're recovering from the procedure. So patient education is really important to send these folks out with. If you get worsening pain, fever, chills, nausea, vomiting, call or go to the emergency room. Yeah.
Thank you. And then one more question, just with helping patients prevent post-ERCP pancreatitis, is it ever worth like keeping them NPO for a certain period of time? Are there patients who are higher risk, or what other interventions could we do, or are there other interventions that we could do to help reduce the risk?
Really good question. So procedural, like prevention of procedural complications, particularly pancreatitis, could be kind of a whole another talk, which is why I didn't get into the weeds of it, but it's a really valid question. So I want to make sure that we address this. So a couple of things that we do for prevention of pancreatitis is we give them a lot of IV fluids during the procedure. So you may have somebody roll out to the post-procedure area and they have 3 liters of LR ordered and you're like, that seems like a lot. That is to help prevent pancreatitis. The other thing we do is the nurses interprocedurally will administer the rectal indomethacin, which can help prevent ERCP pancreatitis as well. Sometimes the physicians will place a pancreatic duct stent as a preventative measure to help improve ductal flow if they think the patient is high risk for pancreatitis. So if they have sphincter of Oddi dysfunction or fall into that category, they're like middle-aged females, sphincter of Oddi dysfunction, we're doing a sphincterotomy. Those people are going to get a lot of fluids. They're going to get rectal indomethacin unless it's contraindicated. And then sometimes they'll get a pancreatic duct stent to help that outflow of the duct in the immediate post-procedure period. But if they're not high risk and the procedure goes well, aside from the IV fluids and the rectal endomethacin, keeping them NPO is not necessarily going to prevent pancreatitis. It might delay their symptoms related to it, but it won't actually prevent the actual condition. Good question. Yeah. So good question. The large majority of the stents will need to be removed. Sometimes when the physicians put in prophylactic pancreatic duct stents, they're very small. And they'll pass on their own after a couple of weeks. So sometimes we'll say get an x-ray in a couple of weeks. If it's not passed, we'll go in and get them out. If a patient has a plastic stent or a covered metal stent, those will have to eventually come out, the timing of which will depend on the condition they were placed for, the type and size of stent, and any other medical issues the patient may have. The caveat to that is if a patient has a malignant stricture or like a pancreas cancer that's causing a bile duct stricture, we will put in an uncovered metal stent to keep that duct open. Those are permanent. So the uncovered stents are permanent. All of the other stents at some point do get removed. Large majority of them are removed with a scope endoscopically. Some pass on their own. Good question. Yeah. Post-ERCP pancreatitis, I don't actually know the answer as to why, but that group of patients, particularly patients like 30 to 50, females 30 to 50, particularly with the sphincter of Oddi dysfunction or papillary stenosis, are at higher risk. They just fall into that category. Yeah. Fun. Yes. Most of the time you can. It depends on what the stent was placed for. If it was kind of like if it was one of our case studies where there was a stricture, we biopsied it, placed the stent, stricture comes back benign. Sometimes we can pull the stent. If it's a bile leak and we're treating the bile leak, oftentimes we have to do the full ERCP. We take out the stent, do another contrast study in the duct to make sure that leak is closed. And if it's closed, then we'll leave the stent out. If it's still leaking, we'll put another stent in. Yeah. Yeah. Mm-hmm.
Basically, the issue would be like you were talking about acute pancreatitis, but in chronic pancreatitis, they just have issues like strictures and other things that are happening that aren't able to be resolved. So it becomes a chronic issue.
So chronic pancreatitis typically develops after multiple episodes of acute pancreatitis from whatever etiology, which there are several. Most of the time it's either gallbladder disease or gallstones or alcohol. So recurrent kind of injury to the pancreas leads to scarring, chronicity of the pancreatitis, and that can lead to narrowing of the duct, which can cause stricturing or stones, which sometimes require stenting. Those people can still get post-ERCP pancreatitis. All those risks are still applicable to patients with chronic pancreatitis. So I think most of my case studies today were all biliary ERCPs, but the pancreatic ERCPs carry the same risk profile. Yeah, sure. Mm-hmm. Just the way their assays work in their lab, whatever they run the labs on. It's confusing. I learned that when I first started working here about 6 years ago, despite having been a nurse practitioner for a long time. I was like, oh, that's not always that 3 times the upper limit of normal. So it's important to look at that range. Yeah. Yeah. Excellent question. So it helps to prevent intravascular depletion. So if a patient is developing pancreatitis and is not yet symptomatic or is still waking up from anesthesia or what have you, the fluids help to keep the fluids in the vessels as opposed to all of it being sucked out kind of into the abdomen for that inflammatory response that can be caused by the pancreatitis. So the fluids can help prevent can help kind of tamp down that episode and or prevent that. So you're not leading to these complicated pancreatitis episodes. So in the same vein, if a patient presents with pancreatitis lipase is high, imaging shows pancreatitis, starting them on fluids right away is really important to help prevent complications, because these people can get bad kidney issues as a result, can get hypotensive, can get septic, can end up in the ICU on pressor support. Sure. Anything else? Thanks, everybody.